Hey Kines 3030, this is Professor Gordon. Today we're going to talk about the shoulder girdle. Shoulder girdle made up of the scapula, attached to the spine, and then we have our clavicle right up front. Again, here's an image of those two bones. We have a lot of different movements of the shoulder girdle. First one being elevation, depression. If we come to a flex position, we can do retraction. Once we extend it out, we get that protraction. And then if we move our arms above or below our head, we can go upward rotation or downward rotation. First muscle, shoulder girdle, is going to be our trapezius. This isn't just at the top of the scap. It originates at the ligamentum nuchae. Also the base of the skull, occipital protuberance. It's also going to attach on our spine, C7 to T12. Going to go all the way down to about the middle of the back. Insertion, this is where our muscle is going to be the most movable part of the muscle. We have the lateral third of our clavicle, right up top. Acromion process, it's going to be located right here. And then we have the spine of the scap. This is going to be the back, posterior portion of our scapula. We have three sections of the trapezius: upper, middle, and lower. Some of the actions of our upper trap, we have elevation. Next up, upward rotation, putting our arms above our head. Neck rotation, looking to the right or the left. And if we're in a flex position, neck extension. Those middle fibers have a lot of the similar movements. Elevation, upward rotation, and also retraction, which is going to be adduction, squeezing our shoulder blades closer together. So with the trapezius, review some of those, maybe some movements that we can use, those actions, maybe some sports, maybe some exercises at the gym. Next muscle, we got the rhomboids. Rhomboid minor is actually at the top of rhomboid major. These are originating on the spine, C7 to T5. Inserting at the medial border of the scap. Actions of the rhomboid. We have a synergist for retraction to the trapezius. This is also our prime mover for downward rotation. Practice some sport and exercise examples for those rhomboids. And our last superior muscle, we have the Levator Scapulae. Origin C1 to C4, so this is going to be the top of the neck, cervical. It's going to insert at our superior angle on that medial aspect, about right here, medial superior portion of the scap. Actions of the Levator Scapulae. It's going to be a synergist to that trapezius for elevation, a synergist for the rhomboid for downward rotation. Now moving on to our anterior muscles. First one, Serratus Anterior. This one's going to originate on costae 1 through 8. Inserting on the medial border of the scapula. Big important fact here, this is going to be anterior, different from your rhomboids, which insert posteriorly on that medial border. Serratus Anterior is going to be anterior medial border. Some of our muscle actions here, this is going to be our prime mover for protraction, also a synergist to the trapezius for upward rotation. Our last anterior muscle, Pectoralis Minor. This is going to originate on costae 3 through 5. Insert on our coracoid process right here anteriorly. Some actions of our pectoralis minor. It's going to be a synergist for protraction. It's going to be a synergist to the serratus anterior. It's also going to be a synergist to the trapezius for depression.
All right, Kinesiology 3030, we are back and we are digital. We're going to review our glenohumeral joint today for your lab. This is our little review. We've gone over it a few times. We're going to go through it again, and then it will correspond with what we're doing today in your lab activity. Remember, our glenohumeral joint is the articulation between our scapula and our humerus. That glenoid fossa is articulating surface with the humeral head. Remember, we talked about our articulating surface with our axial skeleton is our sternoclavicular joint. The articulation between our scapula and our clavicle is our acromioclavicular joint. Okay. So we talked about some different things to consider when we're talking about our glenohumeral stability, mobility. We know that we have quite a bit of instability when it comes to our glenohumeral joint because we lack that structural stability. We make up for it with dynamic stability with our rotator cuff. And we know we have, often in our throwing athletes, deficit with their internal rotation because their tightness, tension in those external rotators from constant repeated eccentric actions. Okay. When we look at the movements of our glenohumeral joint, we have a rhythm between the scapula and the humerus. That's why we go through the shoulder girdle first, understand those shoulder girdle movements here so that we can understand our glenohumeral movements also. Okay, we have our rhythm. Okay, make sure you go through all of our humeral movements that correspond with our scapular movements. This gives us an indicator as we're analyzing movement, what's going on at the scapula based on what's going on at the humerus. The humerus is a little bit easier to see compared to seeing and visualizing scapular movement, especially with clothing and high velocity movements. Okay. So reviewing your movements, go back through each of your movements. We know we have 3 axes, 3 planes. With those, we also have our multiplanar movements, like our horizontal AB and adduction, corresponding with our protraction and our retraction, those transverse plane mixed flexion, abduction, humeral movements, as well as our diagonal abduction, adduction, and our circumduction that we can get in front, to the side, up top, as we mix flexion, extension, abduction, and adduction. So let's go into our muscles. Let's get moving through what we can do at our glenohumeral joint. Right, now that we've gone through our deltoid, we can move inferior down and slightly medial to get to pectoralis major. Pectoralis major is an extrinsic shoulder joint muscle. It's going to give us more strong, more gross motor functions compared to deltoid. Okay, we have 2 different sets of fibers. We have our upper or our clavicular head and our lower or our sternal head. Each origin will correspond with slightly different functions, but they will work together synergistically for quite a few of their functions. And if we look at the clavicular head first, that medial medial third of the clavicle is going to give us our origin, and then the insertion will be on the lateral edge of the bicipital groove. Here, lateral and anterior on the humerus. And we have a superior to inferior origin to insertion. So we know it's going to give us some kind of flexion or anterior movement. It's oblique. We know there's going to be some kind of medial rotation. And if we're in that abducted position, we'll get that adduction and horizontal adduction. Okay? So if we look at the sternal head, down the sternum and onto the costal cartilage of the first 6 of our costals, and the insertion on the lateral edge of the bicipital groove. This is a more medial to lateral muscle. It's going to be stronger in those medial to lateral movements like adduction, horizontal abduction. So clavicular head up first, internal rotation, horizontal adduction, initial flexion, adduction below 90 degrees, and we get abduction above 90 degrees because that angle of pull changes and allows that insertion to come closer to the origin if we are up above 90 degrees or above shoulder height. Okay. With the sternal head, we have internal rotation also. horizontal adduction, extension from a flex position. When we are in that flex position, or we are moved up here, we're going to get that pull down, so movements like pull-ups, chin-ups. We're going to incorporate Pectoralis Major as well as those posterior shoulder joint muscles. Okay, posterior shoulder joint muscles would include something like Latissimus Dorsi, which is our largest posterior shoulder joint muscle. It has an origin from T6 down to T12, down the lumbar fascia and across the iliac crest, giving us one of the largest origins within our body. And then the insertion is on the medial edge of the intertubicular groove, anterior and medial on the humerus. Okay, so we have a posterior to anterior muscle. We also have a medial to lateral muscle, which we can infer most of our actions from those origin and insertion sites. Okay, so our first action, adduction, moving that lateral insertion towards the medial origin. Extension, moving the anterior insertion towards that posterior origin. Internal rotation as we cross oblique and anterior across that joint. Horizontal abduction, especially if we are in a more or slightly flexed position rather than a fully abducted position or a fully flexed position at the shoulder. Latissimus Dorsi also has a small helper called Teres Major. Teres Major is an intrinsic shoulder joint muscle that moves from the inferior angle of the scapula to the medial edge of the intertrabecular groove. So it sits just near that insertion site with Latissimus Dorsi, but that origin is on the scapula. And that weakens the muscle as well as it being a much smaller muscle, but it gives us some slightly different movements. Okay? So internal rotation, synergist for internal rotation, synergist for extension with Latissimus Dorsi, adduction, especially from an abducted position back to anatomical position, but these are only allowed when the scapula is fixed in a retracted or a stable position. Once the scapula begins to move, we lose force from our teres major because it is reliant on scapular stability. That's where those shoulder girdle muscles come in handy as we're going through gross motor functions. Coracobrachialis also is an intrinsic shoulder joint muscle with its origin on the coracoid process, insertion on the medial third of the humerus. So it's another medial to lateral shoulder joint muscle, but this one is anterior compared to teres major, which is posterior. So our actions here, flexion, adduction, horizontal adduction. So we have quite a few extensors and adductors that are large muscles, a few that are smaller, and most of these cause internal rotation. Internal rotation is a primary function when it comes to throwing and interacting with our environment. All right. Now we're going to talk about our four sits muscles, or the rotator cuff, S-I-T-S. Okay, these give us dynamic stability at the shoulder because we lack structural stability from ligaments. We gain it through dynamic stability with the rotator cuff. And this allows mobility in certain planes. It restricts planes in others depending on the movement, depending on the function that we desire, or the movement, the task we're trying to achieve. Okay. Our first of our sits muscles, subscapularis, is our only internal rotator. It sits in the subscapular fossa anterior on the scapula and moves to an insertion on the medial edge of the bicipital groove near where Latissimus Dorsi, teres major, and Pectoralis Major all have their insertion. So it's an anterior insertion, slightly posterior origin site. Okay, this allows us to perform internal rotation, assist in adduction, assist in extension, but really we're trying to stabilize the glenoid fossa, stabilize the humeral head, and stop any kind of anterior translation. We're trying to hold back against that anterior translation. That's where we have the least stability at the shoulder joint. Okay? If we look up top to supraspinatus, is our most superior of the rotator cuff muscles. The origin is in that supraspinous fossa, here superior on the scapula. The insertion on the greater tubercle, here superior on the humerus, to allow stability against inferior translation and to assist in initiating abduction at the shoulder joint. So this is a stabilizer and helps us initiate that movement, but its primary function is to hold us into a nice articulation surface. Okay? If not, we have no other real stability against inferior translation of the humeral head. Okay? If we move posterior onto those external rotators, remember IT in the stitz is our external rotator group. So infraspinatus, the eye, it has an origin on the infraspinous fossa, insertion, greater tubercle, posterior. So those other three, they sit here on that greater tubercle, lateral on the humerus. Okay, but we're posterior and we're oblique to the joint, which will allow us to perform external rotation. They also assist in horizontal abduction and extension and help us stabilize against anterior translation of the humeral head, where we see the most subluxations, the most dislocations. We get them with anterior translation. Rotator cuff helps to stop that. It's also a major decelerator when we're in any rapid internal rotation movements, things like swimming, throwing, especially overhand throw. Okay. Teres Minor is our last of the sits muscle, our smallest next to supraspinatus, helps with external rotation, and it sits with the lateral border of the scapula and posterior on the greater tubercle. So it sits just inferior to infraspinatus and just superior to Teres Major. So Teres Minor sits just superior to Teres Major and performs an opposite rotation from Teres Major. Okay, so don't get them mixed up, don't get those flipped up. Okay, so we get external rotation, adduction, horizontal abduction, extension, and help us stabilize infraspinatus and hold the humeral head in its place. Okay, these all come into play, especially in sporting movements like throwing. Okay, so they help us with acceleration like subscapularis and all of those large axial-based internal rotators, and those IT muscles, okay, those IT in the sits, infraspinatus and Teres Minor, help with glenohumeral deceleration post-rapid internal rotation activities, like a pitcher throwing off the mound. Okay. If we lose that rhythm with our scapula and our humerus, remember we get impingement. Impingement is when our humeral head starts to butt up against our acromion process because our scapula is not moving synergistically with the humerus, and we start to close off that subacromial space. If we close off that subacromial space, supraspinatus goes right through there. We'll often see impingement and rotator cuff tear because we are bringing those two bones together. We're closing off that space. We have nerves, muscle, connective tissue. Okay, so we want to make sure that we can allow upward rotation, allow scapular abduction or protraction so that we can avoid injuries at this joint.